It's a pleasure to be here. It is a beautiful first day of spring, quite an interesting surprise for us. And I'm going to talk to you today a little bit about how we kind of currently diagnose Alzheimer's disease, some of the tools that are being developed to allow us to do that better, and how we're kind of moving to trying to diagnose the disease earlier and earlier. And this is a relatively small group. There's some technical slides, some things that might be confusing, and really I would actually like it to be a little bit of a conversation. So if you do have questions, I'm fine about sort of changing course and talking and answering some of those questions for you. So this is the sign on the road that I think many of us fear, or a lot of people fear. It's the town of Alzheimer, actually, in this actual town in Arkansas. It's very ominous looking, sort of a dark, rainy scene here. And there are a few things wrong. One, they misspelled Alzheimer's. And then also the population is more like 5 million as opposed to this town of 1,000. It's obviously a growing public health problem, and we'll talk a little bit about that, or review a little bit about that in a bit. But what we've found is that before you get to this sign, I'll try to use this as a pointer. Before you get to this sign, there's actually a very long road to go there. And it turns out it's not just this little brief segment of a road, but it's a long highway, and there are many sort of roads leading up to it. And so to be a bit metaphoric, we've been trying to kind of capture the disease at an earlier and earlier and earlier point on that road. And so to make it a little bit more concrete, when we talk about Alzheimer's disease, clinical Alzheimer's disease, we're talking about people at the end of a continuum. These are people who already have a fair bit of the pathology of the disease. And so the main two sort of pathologic things that we see under a microscope that perhaps Dr. Arnold spoke to you about last time are these amyloid plaques. My pointer is not working that well. These amyloid plaques and neurofibrillary tangles. And they actually begin years, if not decades, prior to when people have enough symptoms for me as a clinician to say, you have Alzheimer's disease. And so really compelled by the idea that we will be able to better treat the disease before you get to that point. And also the idea that it would be better to, if you're going to slow down the disease or halt it, to halt it before people have a lot of symptoms of the disease. We've been very interested in trying to diagnose the disease earlier, and that's what's led to something that I'm sure some of you have at least heard of, which is this idea of mild cognitive impairment, which actually is a relatively new diagnostic category. It's really only about a decade that we've been using that in any way kind of clinically. And then what's happened more recently is we've moved into this realm of preclinical Alzheimer's disease. And preclinical means, clinical means prior to when you're seen by a clinician or you go to see a clinician. So when people are essentially normal. And we're trying to find ways to find the disease at that point. And obviously, if you could halt it then, that would be most ideal. So just a little bit of background, and I'm sure Dr. Arnold went through some of this. How many of you went to Dr. Arnold's talk? So let's say like more than half of you. So for some of you, it'll be a little bit of review. Some of you, it'll be a bit new. He probably showed this slide because I stole it from him. Don't tell him. So basically why we're interested in Alzheimer's in particular, and it's not that we're not interested in other forms of dementia, is it's the most common form of dementia. And a common question is, what's the difference between dementia and Alzheimer's disease? And it's essentially the difference between fruit and apples. So dementia is fruit, and apples is a type of fruit. Dementia is a very broad term, and Alzheimer's is a type of dementia. And Alzheimer's just happens to be the most common form of dementia. And it probably makes up at least half, but most likely about 3/4 of all dementia that we see, particularly in a population older than the age of 65. And this is actually the very first patient that Alu Alzheimer described. It was actually a very atypical case. It's a woman around the end of the 19th century, beginning of the 20th century, who developed her symptoms in her 40s. So a really sort of dramatic case. And there are people with genetic forms of Alzheimer's who do develop the disease quite early in life. And even in their 30s in some instances. This is her trying to write her name and address, and she struggled with this. She did something that patients sometimes do as they get more severe with the disease, in that they perseverate. So she kept writing the word Frankfurt as her address. And then these are some drawings that Alzheimer, the physician who took care of her, drew of some of the pathology of the disease. And these are actually turn out to be the tangles that we now talk about. So again, the details of this aren't super important, but they do relate to some of the tools. Turns out they're probably very related to each other, in that they both play a role in the disease. Amyloid might play a more early role, or sort of antecedent role, in sort of pushing tangles to form in the brain, but tangles definitely play a big role in neuronal function, and ultimately neurons, which are the cells in our brain, are the sort of workers for how we think. And so if they're damaged, we can't think as well in that setting. So why is Alzheimer's and dementia becoming such a big issue? Well, the reason is, no matter what your race, no matter what your education, your socioeconomic class, and no matter what country you're in, the biggest risk factor for Alzheimer's disease is age. And there's really a doubling of risk from the age of 65 on to 90. Used to be thought, actually, when people got into their 90s, that once you've made it, you're not at risk anymore. And there's actually been some more recent data to suggest, no, it continues to double, actually, as you get older and older. And so given that the disease is related to aging and getting older, we have an issue in that our society, particularly in third world countries like the United States, is getting older too. So actually, I think just a couple years ago, we finally got to the point where there are more people over the age of 65 than under the age of 15. And so that's been a real shift in the demographics of the third world and of countries like the United States. And I don't know why this keeps going on its own. I might just try one thing here, because sometimes it's on this little, it wants me to hurry up. Nah, I'll just keep going with it. Sometimes it automatically sets these timings, and yeah, it's getting bored of listening to me speak. It's like, I want to get out of here. So what's happening is the fastest growing demographic in our country right now are people over the age of 85. And so if you sort of multiply together the fact that our population is aging and that the biggest risk factor for Alzheimer's is age, then what you have is you have a lot of people developing the disease. And so if you look at the numbers, in 2010, we had 4.7 million people in the United States with Alzheimer's disease. And by the year 2050, given sort of projections of the population, we expect about 14 million people in the United States to have the disease. So essentially a tripling of the number of people with it. And it's expensive. So right now, this didn't show up on the y-axis, but right now we spend about $200 billion a year on people with Alzheimer's related to their medical care and to their overall care. Turns out there are probably costs that we don't even include in that, like caregiver, time loss, the medical care that's required of family members who deal with the stress and other issues of taking care of a patient with Alzheimer's disease. And so it's expensive, and actually it's projected, inflation adjusted, that by the year 2050 we'll spend about $1 trillion a year on this disease. So it really is a disease that we need to take care of now, because it's going to have economic implications. And one thing that's somewhat encouraging is if we could find ways to slow down the disease, even just slow it down a few years, we can have a major impact on the number of people who go on to develop the disease. And so, for example, sort of modeled, if we slowed down the disease by 5 years, like we prevented it from occurring either till 5 years later, or we just kind of slowed it down at the earliest symptoms of the disease, we would essentially keep the numbers of people with Alzheimer's disease the same in the year 2050 versus now. And so that's really a major goal in the field. So how do we diagnose it? Well, it's easy when someone's like this, when someone is at the point where they say, I may have Alzheimer's, but at least I don't have Alzheimer's. So if your memory is that bad, it's pretty obvious that you have something wrong with you. And this guy's pretty happy about it, so you can't. But the reality is it's often not that easy. And so why is it hard to make a diagnosis of Alzheimer's disease? Well, the problem is, and this is always, I should always warn people that this is the sad slide of what happens to our brain on age to some extent. But as we get older, really starting in your 30s, there's a relatively steady decline when you look across populations of certain areas of thinking. There's certain things that actually get better with age, actually, certain aspects of sort of social cognition and aspects of language get better as you get older. But memory, particularly memory for recent events, and our kind of ability to hold information in our head at the same time, that goes down relatively steadily as we get older. Again, really starting in your 30s. Another thing that we have trouble with as we get older is kind of retrieving information. We have a lot of that information there, but we have trouble kind of pulling it out. Something that we all experience, like trying to come up with the word you want to think of, or someone's name, or an actor's name. It's just difficult to pull that out. And so in the face of just kind of normal age changing, one of the things that we struggle with as clinicians is, well, how do we know that the kind of memory problems that someone's complaining of really reflect something that's a disease versus just kind of the normal aging process? So what is dementia? So I mentioned, again, it's a generic term. So you know clinically there's an actual kind of criteria for what we call dementia, and it's actually not all that, it's not like a blood test where you go and you get a number and someone says you have dementia. It's criteria that has a fair bit of wiggle room, which adds to some of the noise in our ability to diagnose it and what different people call dementia. But essentially all dementia is clinically is when people have decline in their thinking to the point where it's affecting their day-to-day function in a significant way. Now, what does that mean? That's hard to sometimes determine. What's affecting people's function if someone is retired and not doing a lot during the day versus someone who's on the board somewhere or volunteering. It's sometimes hard to judge how much your function's being affected based on what your function is. But that's essentially what it is, and then you need to provide some sort of evidence, and this is where the clinician helps, that you're impaired in at least two areas of thinking. And we use different kinds of tests to determine this. The main areas we look at are things like memory, remembering what you had for breakfast this morning, remembering something you did a week ago. That's something that we refer to generically as short-term memory. We look at visual spatial functioning, your ability to kind of know where things are in the world and to perceive objects. We look at your language, word finding, using the correct words, understanding language. We look at things like judgment and abstraction. The bottom line is that if you have impairment in two of these areas and it's enough to affect your function, and it's a change from your prior level of functioning, that's how we clinically say you have dementia. And again, you can see that this is kind of vague in some sense. And then Alzheimer's, and these are actually newer criteria. We actually, to give you some sense of where the field has been, we have been using the same criteria for Alzheimer's disease since 1984. And that's just when people even thought of Alzheimer's disease over the age of 65 as even being a disease as opposed to just old age. Just a couple years ago, actually, there have been some alterations to the criteria. But basically, Alzheimer's is just a form of dementia that is slow in onset, and that memory tends to be an early symptom of the disease, although there are some variants of Alzheimer's where that's not the case. And you need to kind of rule out other things. So like you want to make sure someone doesn't have strokes or some other condition that can cause their symptoms. And then again, as sophisticated as we are, we just sort of break our clinical judgment into probable or possible Alzheimer's. Probable Alzheimer's is when they have all these kinds of symptoms, They have memory loss, and it looks like kind of a typical disease. Impossible is when, well, it could be some other thing that we think, or it looks a little bit like this other form of dementia. And so that's the kind of judgments we make, and those are the kinds of judgments that are made actually when people enter clinical trials. And that's part of why I think we've struggled as a field to some extent. And just to be a little more concrete in what we do, if you were someone who came to our memory center at Penn, is the way we get at this information is mostly, I mean, I would say like 90% of how we make our diagnosis is just from talking to patients and their family members. Much of this is the history. What kinds of things were they able to do 2 years ago? What kinds of things are they struggling to do now? How is the course of what's been happening? What are the kinds of things in terms of their thinking that they're having trouble with? Do they have trouble remembering appointments? Do they have trouble remembering an event or going out to dinner the week before? Would they not remember the details of that? We go through things related to medicines that our people are on. One of the things that we have to deal with a lot in older adults is they're on a lot of medicines that can affect thinking. And so really being a good clinician is to look through those and say, okay, maybe this person is having a little bit memory problem, but this drug right here could be the cause of it, and let's see what happens if we switch medicines. Family history is important. There is some genetic risk to the disease. In particular, there's a familial risk where a first-degree relative increases your risk of the disease. So if your parent had the disease, you're at somewhat of an increased risk. It's a little bit more if it's maternal than paternal. So if your mom had the disease, it's a slightly higher risk than if your father had the disease. So that plays into it. Although again, in reality, it's such a common disease that as we're seeing people in their 70s and 80s, it's hard to not have family members that have the disease just because it's such a common disease. And then we do a physical exam on people, and actually in Alzheimer's we expect the exam to be normal, neurologic exam. And then we'll often do some sort of testing of thinking, and this is one that is probably the most famous one, called the Mini-Mental Status Examination, which was developed actually in the 70s by a psychiatrist at Johns Hopkins. I used to actually work in his office, and he was already sort of emeritus at that point. But basically these kinds of tests are screening tests that test different aspects of memory and language and visual spatial function. This is not a particularly great test, actually. This is kind of a screening test, but what a lot of primary care doctors will use. It's very much geared towards testing memory, and so there are other forms of dementia that it's not as sensitive to, and some of the questions are too easy on it. So for example, the naming questions, or can you name a pencil or a watch, those tend to be things that people with Alzheimer's disease don't have a problem with until very far into the disease. And so it's not the most sensitive measure, but these are the kinds of tools that are generally used in clinical practice at a center like our own, where we have more sort of resources based on, to some extent, grant funding, and philanthropy. We're able to do a bit more testing than this. So we do a bit more sort of rigorous types of tests of different domains, and then we look at how your testing is relative to other people in your age range. So how good is clinical diagnosis of Alzheimer's disease? Like, how accurate? Do you guys have any sense of how accurate we are? Anyone? That's right. So the only way to have definite Alzheimer's disease is to take someone's brain out and look at it under a microscope. And I have yet to get a patient who's like, here you go, take a look, and then put it back in, and we'll all be fine. So patients don't like that. I don't like that. And we don't biopsy patients for this disease. There are some diseases that we do brain biopsies for, I should say, but this is one where we wouldn't, because it would cause more problems than it would help. So in terms of how good we are, we're not that good. So sensitivity and specificity are complicated terms, but essentially what it means is that when someone has Alzheimer's disease, if you look across studies, we're about 80% of the time we pick it up. So 20% of the time we miss it. And then specificity is sort of the other interesting thing. We often call people as having Alzheimer's disease when they don't have the disease. And so 30% of the time we say, you have Alzheimer's disease and you don't. And actually, if you look at studies, and that's what these parentheses show, the range is incredible. So there are some places where in some studies where your specificity is only 23% of the time, meaning that 77% of people that you call Alzheimer's or that don't have Alzheimer's disease, you say they have Alzheimer's disease. And so our accuracy is somewhere on the range of about 75% of the time. So 3/4 of the time, we're right about the diagnosis. Now, arguably at centers like our own, where we actually do have autopsy data, we do better than that. So we're more on the kind of 90% range, but we're far from perfect. And in reality, we also have a pretty selected or biased group of people who come in, so it's a bit easier for us than it would be in a sort of general clinical practice to make the diagnosis. So how can we make it better? And that's really what we've been working on, what a lot of my work is on. How can we make our diagnosis more accurate? And so this is where, and I'm sure Dr. Arnold spoke a little bit about this is where biomarkers become important. This is where tests, and all a biomarker is a test. And it's a test for trying to pick up evidence of the disease that we're studying. And so what has been developed over really the last 10 to 15 years, and still relatively new how we've been using these, are tools that allow us to pick up on brain degeneration, and all that means is brain injury that accrues over time. So we've developed tools where we can sort of see brain injury, either by measuring the structure of the brain, so seeing if the brain's shrinking, as well as actually molecular markers, the markers that pick up that amyloid and tangle pathology that tell us whether there's likely to be that in the brain. And this has been a real kind of revolution in the field over the last 15 years. And I would argue, and you'll see, right now we have gotten to a point where we can be pretty precise about some of these things, about making diagnoses. And that's moved beyond where we are from a treatment standpoint. And so I think the first step to get to better treatments is to be able to better diagnose the disease. For example, in a clinical trial, you want to make sure everyone in that trial has the disease. Otherwise, it's hard to test the drug to see if it works. But I would say we have moved to a pretty advanced stage at this point. So these are the kinds of markers, and I'll sort of show you some of them. Oh, before I do that, actually a couple other points. One is we have also developed a model over time of how these biomarkers change at different points within the disease course. So this is a figure that's shown all the time in our meetings, and I don't think the details are super important here, other than to know that there's a continuum from going from being normal to this kind of pre-symptomatic stage to mild cognitive impairment to dementia or Alzheimer's disease. And these different biomarkers, these different tests, seem to get abnormal at different points in time, and they seem to track the disease better or less well at different points in time. And so one of the things we've been really trying to work on is to map this out, to try to figure out when we should be getting these different tests and how they can sort of predict when people are going to have symptoms or what their symptoms should be. The other point I just wanted to make was the pathology of the disease, these plaques and tangles, they evolve, and this just shows a map of where they go in the brain. They are actually evolve in different places in the brain to some extent. So they overlap to some extent, but not completely. And it's relatively stereotyped, that the pattern. So in most people, tangles affect the brain in the same pattern over time. And why is that important? That's important because that actually helps us with diagnosing the disease, because different parts of the brain are involved in different parts of thinking or different types of thinking. It also helps us because we can then, when we look at brain structure, focus on the parts of the brain affected at different stages of the disease. And most importantly, tangles, the area that's affected first is this area up here, which is the medial temporal lobe, or where the hippocampus sits, and that's the workhorse of your brain for memory. That's the part of your brain where memories are formed and stored. And so the earliest area that tends to be affected in this disease is that part of the brain. And that's why memory is something that we really spend a lot of time testing when we test for this disease. And actually, when we see patients, we clinically look at brain scans and try to assess these things. And so in our general clinical practice at this point, we will get an MRI, and this shows that part of that brain, which is that the medial temporal lobes of the hippocampus. They're right here and here. This is kind of a cut, like as if your eyes are eyeballs are out here, and this is sort of slicing through the head this way. And they're called medial temporal lobes because they're kind of in the medial part of the brain, and this is the temporal lobe. And what we do is we just look at the scans, and qualitatively we see in patients that this patient has Alzheimer's disease, that part of the brain is particularly shrunken in this person who has memory problems relative to this person. Okay? And so when we see that, we know, or we at least strongly suspect, that this is Alzheimer's disease because they're showing changes in their brain that are consistent with the disease, that they're showing an area of the brain that's most affected by the disease, that they have shrinkage in it. Now, it's not that easy to look at these things, and sometimes it's just, you can't tell. You're basing it, you don't always have a normal brain to look at next to it. We also don't know what someone's brain looked like 15 years ago, so it's hard to judge. And the differences can be quite subtle. So one of the things that we're developing and that we actually now use at our center are automated methods that actually use a computer algorithm that knows where the hippocampus is in the brain, can trace it, and then spit out to us where that particular person sits relative to other people their age. I should mention that your hippocampus, even with normal aging, does get a little bit smaller as you get older, even in the absence of disease. But we can look and we can see that this person, they're right here, and this sort of red sort of line here, in between this is what we see in someone with Alzheimer's disease, whereas someone without Alzheimer's disease is in between these sort of green lines. And so we can actually look in a very quantitative way at how big someone's hippocampus is, and that can help confirm or support our clinical diagnosis. And these kinds of tests actually really do improve our ability to detect the disease. In fact, just to give you some of the work that we've been doing that I think is kind of cool, is that now we've gotten to the point where you can look at a scan like this and find the hippocampus, but we have really special algorithms now that can pick out little parts of the hippocampus, and there are different parts that are affected more in Alzheimer's disease than in other conditions, and we can actually sort of take out that part of the brain and form an image of just sort of the medial temporal lobes, the hippocampus, and look at where there's changes in the brain relative to normal people. And red areas here are where there's thinning of this part of the brain. And it turns out that that area of thinning is precisely the area where there are tangles that first form in the brain at the earliest phase of the disease. And so we're now, and this is also automated, so we're now trying to get to the point where we can really at a very fine level detect whether someone has brain changes that are very specific to Alzheimer's disease. There are other kinds of tests that physicians will sometimes get in these instances, and I'll go through a couple of them. Outside of brain structure, they cost variable amounts. MRI is probably believe it or not, the cheapest thing that we can get in individuals who come into our clinic. This is something called glucose PET or FDG PET, which measures brain metabolism. So just like how I like to eat sugar, your brain likes to eat sugar, particularly after it's been active. And there are certain patterns we see in the brain of changes in metabolism that look more like Alzheimer's disease versus other conditions. And I should just take a step back. In general, what we're looking for in all of these tests is how much your brain looks like an Alzheimer's disease brain. And the more it looks like that, based on any of these tests, then the more likely our clinical diagnosis is right. And so a normal person has a lot of brain metabolism all throughout the entire cortex. Where it's red, it means there's more metabolism. Alzheimer's patients tend to have less metabolism in back parts of their brain, which actually happen to be connected to that memory circuit, the medial temporal lobes. And then other conditions, there's another form of dementia called frontotemporal dementia. They show decreased metabolism actually in the front parts of the brain. And the important point is that these kinds of tests not only help us to say you have Alzheimer's disease, but sometimes can help us differentiate between other forms of dementia, which have different patterns, because all these diseases, while they can look kind of the same to people, when you actually look at the brain and what's affected, they actually seem to affect different parts of the brain. And so our job is to try to disentangle which one looks more like that individual patient. Not to belabor this, but there's also spinal fluid markers that we have as well that actually pick up A beta and tau, and they make up the plaques and tangles. And we can actually measure that quite precisely. Penn is really the leading place in the world for developing this particular measure. And it has very high sensitivity to picking up Alzheimer's pathology in the brain. So we've even done postmortem studies where if you do a spinal fluid study and then look at a brain at autopsy, it's about correct 96% of the time in picking up the amyloid plaques in the brain. So it's a much more sensitive measure in many ways than other tools we have. And then the big thing, which I think most people have heard about because it's always in the New York Times, or was a couple of years ago, although now maybe it's already become common practice, is something called amyloid imaging. Have you guys heard of amyloid imaging at all?
No.
Some? None. So amyloid imaging is another form of PET. PET scans are, we have CAT scans and PET scans. We like animals in medicine. So PET scans are positron emission tomography, but we like to call it PET because that's really hard to say. And basically it involves a little bit of radioactive material, and that radioactive material is sort of tied to a molecule that can then bind to some part of the brain. And what's been developed is ways to get that radioactive material to bind to the amyloid plaques of Alzheimer's disease. And this truly is a major, major revolution in the field, where now we can actually visualize, to some extent, what the pathology would look like under a microscope in a scan, where you can actually see the amyloid of the brain using these tests. And so in an Alzheimer's disease patient, they have a lot of this amyloid, and so the redder it is, the more amyloid there is in the brain. These are, and we'll talk a little bit about mild cognitive impairment in a bit, these are two people with mild cognitive impairment, one of which probably does have Alzheimer's disease and the other doesn't. So normal people tend to have none of this amyloid uptake in the brain. Yeah?
When you establish using one of these markers that you have a patient with MCI or beginnings of Alzheimer's or whatever you think, do you then use that as a baseline and do further tests of the same type to see if there's a progression? Or once you've established it, you just deal with it?
It depends. In clinical trials, we definitely follow these kinds of markers because we're trying to see if we're changing the trajectory of the disease. And it turns out these markers, and I'll talk a little bit about this if we have a chance, these markers, some of them are better for tracking the disease change over time, and some of them are better for just picking up that there is disease. So it turns out amyloid imaging is not very good for tracking the disease. Once you have amyloid in your brain, it kind of stays relatively flat, maybe goes up a little bit. And so it's not as useful for sort of tracking the disease. Right now, clinically though, we don't tend to do these, because the most important thing when we're seeing people clinically, actually, and what we do track is their thinking. And that is more important to us than what we see on the scan for following people up. I think there'll be a day where that's not the case, where we actually will use these kinds of tests to follow people over time. Yep.
In our early discussion with Dr. Arnold, it came out that there are actually two different types of amyloid. One is beneficial and obviously the other is a problem. How do you distinguish, the first one, is that true? And then secondly, if that is true, how do you distinguish between the good amyloid and the bad amyloid?
Yeah, so I'm not sure that it's necessarily good and bad.
Right.
There are certain forms of amyloid that are more likely to form the plaques, and there is this notion that the plaques themselves may be protective in the sense that amyloid in a soluble form, not to get too complicated with this, but amyloid that's not something that you can visualize in the brain, that's not a plaque, so it's like kind of like soluble like salt in water where you can't see the salt. That form may be the more toxic form of amyloid. That we don't pick up with our scans. That's something actually in spinal fluid that people are very interested in being able to better pick up. The reality is that the plaques that we see here are kind of, even if they're not the main thing that's causing the sort of symptoms of the disease, they're always associated with the disease. And so in this instance, it's a kind of like what we call a surrogate marker for the disease. So it doesn't matter whether or not it's good or bad, it just sort of tells us that the disease is there. And we can't differentiate that. So it turns out actually, so amyloid imaging was like this big deal came out, and actually this was part of why I went to Pittsburgh for a while, because it was developed there. And it was called PIB, was the first one, because it was Pittsburgh Compound B. And it was a huge deal in the research world, but it used a special kind of tracer called carbon-11, which for the PET scan, which basically disintegrated within like 40 or 50 minutes. So you can only do it at very sort of high-powered centers where they can actually make the molecule themselves. And what has really changed is that we now have newer forms that actually don't use carbon-11 and that use something called F18, which is just another radio tracer, where it actually can be delivered to sites all across the country at any kind of medical center that has a PET scanner. And there are now a number of these different kinds of amyloid imaging agents, and we've done, as well as others, work to show that when you see amyloid in the brain, you also see it on histology specimens. So this has been a really well-tested measure that we actually have a lot of data where we have people who were scanned. We have data of people who were scanned and actually, for another reason, actually had biopsy tissue of the brain taken out, and there's a matching between the amount of these amyloid plaques and what we see on the scan, and there's actually also autopsy studies. So this is this method works, is basically the bottom line. And now there are several of these tests that are FDA approved. One of them is called Amyvid, another's flutamidamol. I think theirs is Vizamil is the name for theirs. But these are now FDA approved tests that you could get in essentially at any center. The problem is they're not covered by insurance, so no one's getting these right now, actually. This is not something to worry about, other than to say the field has moved where there's an argument now to include these markers in our diagnosis. So I mentioned in the past we were using the same diagnosis that we used in 1984. There's now criteria for, at least at tertiary care centers like our own, that you can incorporate these tests to help you make the diagnosis, and they certainly improve our accuracy. And in fact, they probably help in mild cognitive impairment, which is really where the field has moved clinically to try to diagnose people before they have a lot of symptoms of the disease. And so what is mild cognitive impairment? Again, I'm assuming most of you have heard that term before. Some, not everyone. I think there was like William Shatner in that show Boston Legal had mild cognitive. There was like an episode where he had. So it's gained more attention. So mild cognitive impairment is something that was really, I would say, I mean, it was talked about for about 20 years, but really in the last decade and a half was developed as a kind of criteria or sort of diagnostic category that we can use to try to capture people who are not in that dementia range of impairment, but are having some symptoms, to try to diagnose the disease earlier. And we've developed criteria for that as well. And again, they're pretty vague. So basically, they're when people have a memory complaint or some other aspect of memory or thinking, maybe language is a problem, that they show some objective evidence of impairment on testing. So we do some kind of memory test with them, and they say they have a problem, maybe their spouse says they have a problem, and then we do a test and it shows, yeah, they're a little bit below what we expect for their age on testing. They need to be intact, though. These are people who can sometimes work still. They can still function generally. Maybe, yeah, their memory sort of makes things a little harder for them to do, but they're generally functioning pretty well. So unlike people with dementia who are having more functional problems, and therefore they don't meet criteria for dementia. Again, these are kind of vague. I mean, we could all sort of have disagreements about whether any of us have this. So right, so they're pretty vague, and this is what we've been using though. And so the question is like how well, when we say, and often we talk about amnestic MCI because we're talking about people who have memory problems as their form of mild cognitive impairment. So the goal is to find patients with mild cognitive impairment who are enriched in Alzheimer's disease, because we want to find people with mild cognitive impairment, that their mild cognitive impairment is due to Alzheimer's disease, which then means that we're getting the disease earlier. Does that make sense to everyone? So it turns out actually it does pretty well, despite that vagary, in finding people enriched in Alzheimer's disease. So, not the most specific criteria in the world, but when we have looked at this in centers such as our own, and you say you have mild cognitive impairment, about 10 to 15% of those people per year go on to develop more obvious symptoms of Alzheimer's disease. And that's relative to sort of people who are normal their age, who only about a couple percent or 1% a year would go on to develop Alzheimer's disease. And over 5 years, around 50–60% of people go on to develop Alzheimer's disease. But the important point is not everyone does, okay? So there are 40% of the people that don't go on to Alzheimer's disease. And so mild cognitive impairment is kind of a tricky diagnosis. Some of them have other things going on that are causing their memory problems. And actually, it gets even trickier, and I think this is a really important point, and that is in clinical practice, in just sort of the community, not at centers like our own, the numbers that go on to develop Alzheimer's disease are even lower, okay? It's a less specific diagnosis. So this is sort of a complicated figure, but basically the point is that the top line there are the proportion of people over 5 years or 4 years in a community setting that go on to develop Alzheimer's disease with mild cognitive impairment. And it's only about 15% of those people, whereas in a center like our own, a more specialty center, about 60–70% go on to develop Alzheimer's disease. And the only reason I bring that up is because I think, and this is as consumers of healthcare and just in general, that you should know that when your primary doctor says you have mild cognitive impairment, and then you go and look up on the Alzheimer's Association about mild cognitive impairment, and you see that you have a 60% chance of developing the disease, that's probably not right. And a lot of our community doctors don't understand that they're dealing with a noisier population. They're not doing, and noisier I should say, not that you're louder, but that you have other comorbidities or other issues that make it harder to make the diagnosis than at a center like our own. They don't do the kinds of rigorous testing that we do in our own center because they don't have time and they don't have the expertise. And that's not, I think it's not in any way to sort of belittle what they're doing. It's just, it's a hard diagnosis to make. And so one should just keep in mind that if you're told or a family member's told that you have mild cognitive impairment by a primary doctor, even a general neurologist, and you look up and read the research about it, it probably doesn't mean that you're at quite as high risk as it is suggested in some of these studies. And so when people have mild cognitive impairment, what is it? So it often is Alzheimer's disease, but it's often a lot of other things too. And probably the one that most often it is particularly when people just get into that area of where we say you have mild cognitive impairment is just normal aging. So just like all of us age differently in all sorts of ways, some people have a little bit more problem with their memory than other people. And so a lot of times mild cognitive impairment is just someone who has a little bit more memory problems. They're kind of at the lower standard deviation cutoff of normal for their memory, and it's just normal aging, and we're saying it's mild cognitive impairment. There are other things though, medications, depression's a big one, and anxiety. That's another thing that can cause people to have memory problems that when we test them, they don't do as well as they should, but it turns out that it's, once you treat their depression or their anxiety, they do a lot better. And in fact, just another little side note, in community studies of mild cognitive impairment, as sort of evidence of this, there's a lot of what we call reversion to normal, where people actually, instead of going on to developing Alzheimer's disease, actually when they come back year 1, year 2 later, they no longer even qualify for mild cognitive impairment. They now look normal. Yep.
What about being a diabetic?
Hold on, can we try the microphone so we can hear?
Before you were growing back, talking about an FDG glucose, being a diabetic, does that have anything to do with your memory?
So that's a great question, and I think probably Dr. Arnold spoke a little bit about this because he has an interest in insulin and the relationship of hyperinsulinemia, which is part of what you see with diabetes and cognition. There is a link between diabetes and Alzheimer's disease, and also with dementia. With regard to the FDG PET scan, actually, if you have diabetes, that glucose PET scan, you actually can't necessarily get that scan. So it actually it makes that test not work as well in people who are diabetics, depending on what their glucose level is at the time of the scan. And so we check glucose levels in people before they get scanned.
Would changing
change in medications, would change in medications make a difference in the mild cognitive impairment?
Yeah, so that we definitely see that. So again, some proportion of people who your doctor says you have mild cognitive impairment, they actually don't have underlying Alzheimer's disease, and many of them actually go on and do much better in follow-up years if you've changed their medicines around, or again, if you treat their mood issue. Yep.
Are there typical medications that cause or affect mild cognitive impairment?
Yeah, so there are probably a group of medicines that affect memory that are ones that we most commonly look for. There are what are called anticholinergic medicines, which are medicines that actually block the neurotransmitter that memory drugs that we use in Alzheimer's, like Aricept, try to increase. And actually with aging itself, those levels go down for acetylcholine, which is what these medicines block. There are also medicines like benzodiazepines, which are used to some extent for anxiety, that can make people a little bit foggier. Anything that basically affects the central nervous system can have this effect, but there are certain classes that we look for most commonly. So given the complexity of mild cognitive impairment, how can we better diagnose who amongst those mild cognitive impairment patients actually have Alzheimer's disease? That's really our goal, because those are the people you'd want ultimately to treat, because if you could stop the disease at that point, they're still functioning well, that would be good. And ultimately, those are the people we want in clinical trials, because we think that drugs are going to be better in people, work better in people who don't have a lot of injury to their brain. And so this is where, again, biomarkers help. And the bottom line is, and I won't belabor this point too much, but if we measure things like your hippocampus, the more it looks like Alzheimer's disease, the more likely your mild cognitive impairment is due to Alzheimer's disease. And so we can actually stratify people based on these studies and say your risk of developing the disease is much higher because your brain looks more like an Alzheimer's disease patient, or your risk is quite a bit lower. We also use amyloid imaging for that, and so what we've seen is in mild cognitive impairment, about 40 to 70% of people, depending on the study, are what we call amyloid positive, meaning that they show the amyloid of Alzheimer's disease, and the rest aren't. And again, just like with Alzheimer's disease, there's more and more interest in incorporating these biomarkers, these tests, into how we deliver information to patients about their overall risk that it could be due to Alzheimer's disease. One important point, though, is while we're getting better at saying the likelihood that you're going to progress, another thing that we're trying to figure out is when you're going to progress. That's pretty important to people, too. Like, I'd like to know if I'm going to develop Alzheimer's disease, whether it's going to be 1 year from now or 5 years from now. That would make certainly a difference in my life. And so one of the things we've been working on is knowing these kind of curves, finding the ones that in the mild cognitive impairment stage tell you whether you're closer or not to getting to the point where you're moving into Alzheimer's disease. And so basically one of the things that seems to help us is brain structure. So the more shrinkage there is in certain parts of the brain, the closer you are to Alzheimer's disease. And we have data, and again, don't worry about the figures, but we can predict based on the amount of atrophy in the brain whether you have mild cognitive impairment, whether you're going to develop the disease in 1 year versus 3 years with some degree of accuracy. Not perfect, and these are things that are still evolving, but that's really where the field wants to go, because those things may mean a lot to patients and families. And then very briefly at the end, because I know that our time is running out, as is probably the battery on my laptop. We've now really reached a brave new world of trying to diagnose this disease before anyone has symptoms of the disease. And it turns out when we do amyloid imaging studies, above this line is abnormal levels in a part of the brain that we tend to see a lot of amyloid. And Alzheimer's disease patients all are above that line in this study. And mild cognitive impairment in these purple balls, some about half are below the line, half are above the line. But these are normal people. And yeah, most of them are below that line. But Actually, about a third of them are above that line, or a quarter of them are above that line. So they look like they have amyloid, and many of them, are kind of transitional. They're lower than what we see in Alzheimer's disease, not quite there, but some of them actually have just as much amyloid in their brain as Alzheimer's disease patients. So these people are normal but have Alzheimer's pathology in their brain. And it's very consistent with the fact that when we do autopsy studies in normal people, people who have no cognitive problems, about a quarter to a third, once you get over 65, have Alzheimer's pathology in their brain. That the pathologist, if they were told that you had memory symptoms, they would say, yeah, this is in keeping with Alzheimer's disease. So what's the deal with these people? Again, we can see that people have these abnormalities, and this figure, and I'll just explain it because it gets a little too detailed. All this shows is that as you get older, the proportion of people with this who are normal get higher. So by the time you're in your 8th decade, depending on your genes that you're carrying, you either have a 66% chance or a 45% chance that you have Alzheimer's disease in your brain. Those are pretty high numbers, right? And so that means that like when you're in your 80s, about half of people have some degree of Alzheimer's pathology in their brain, even though, and this is of people with no symptoms. These are normal older adults. So the question is, what does that mean? Are these people who will go on to develop Alzheimer's disease if they live long enough, or are they resistant to Alzheimer's disease in some sort of way? Well, it does seem that they're at greater risk to some extent. So this is one study, and we actually, I should say, don't have a ton of data about this yet. I mean, if you think about it, amyloid imaging was developed in 2004 and wasn't really sort of used very frequently until several years after that. And so we don't have a lot of data of healthy older adults who have this evidence of amyloid and what happens to them over 10, 15 years. But over a few years, they're clearly at higher risk. So about a quarter of them in this particular study went on to develop symptoms, it's starting to fall off, went on to develop symptoms within 3 or 4 years of their scan, whereas none of the older adults who didn't have amyloid developed symptoms. So there clearly is an increased risk. But I should say, we have people at the memory center who we got spinal fluid on who are normal, who have levels of amyloid in their spinal fluid, which gives you the same information as these amyloid scans, in the late 90s who still don't have cognitive symptoms. And so there probably are people who, for whatever reason, for a very long time can harbor this pathology without developing symptoms. And I'm going to kind of gloss over this, other than to say that we're trying to now come up with ways within normal people who have evidence of amyloid to differentiate those who are at more risk that they're going to progress in the near future versus those that aren't. And again, why is that important? Why do we want to know that? Well, think about it. If you're a 65-year-old person and you have amyloid in your brain and you're told, in 3 years you're going to start to develop symptoms, you might be willing to take an expensive or potentially toxic medicine that would help with that if one were available. You might say, you know what, I want to be aggressive about this. Whereas if you're an 80-year-old who has amyloid and you're not going to develop symptoms for 10 or 15 years, you might say, you know what, I'll just sort of let time play its course, and I don't want to take this potential medicine that might make me not feel as well for one reason or another. And so that's really important, and also it's important from a public health perspective in terms of how we allocate resources.
Can you corroborate the possibility of Alzheimer's by doing a genetic test, the EP04 or one of those genes that supposedly has a major marker in identifying whether you will get the disease or not?
Right, so the question is, can we use genetics to help us make the diagnosis? And it,
Or corroborate it.
or support it, yeah. So the ApoE4 gene is definitely associated with a higher risk of the disease, but many people with the disease don't have the E4 allele, which is just, there are 2 copies of every gene, and the E4 allele increases your risk of the disease by a couple-fold for each one that you carry. So it can be helpful information, but it doesn't necessarily distinguish. There are many people with the disease, about half, that don't have that aren't E4 carriers. So it's helpful for risk stratification, but it's not so helpful diagnostically.
Dr. Wolk,
Yep.
can I get this? It helps for the taping so the people are going to watch.
I had 11 Down syndrome clients on my caseload,
Yeah.
and every single one of them developed Alzheimer's, as you would know. So evidently, having trisomy 21 puts you at greater risk.
Yep.
So could you speak to that?
Yeah, no, that's a very interesting phenomenon that wasn't really appreciated, I think, until about 15 years ago, 10 years ago. So trisomy 21, probably why people develop Alzheimer's with that, is that the amyloid precursor protein is on chromosome 21. And actually, some of the autosomal dominant forms of the disease, and autosomal dominant means they're the kind of genes that if you have the gene, you're going to get the disease, and if you don't have the gene, you're not necessarily going to get the disease. So like your children would have a 50-50 chance of having it. Many of them are on that amyloid gene on chromosome 21. And so people think that trisomy 21 is kind of a dosing effect where you've now added 50% more of that gene in your body, and so you're producing more amyloid, which then produces these amyloid plaques. And so that's probably the connection. In fact, trisomy 21 is one of the real strong arguments that amyloid is important in causing the disease because of that link. Just two more or three more very quick slides. We are now moving at our center and others to now do treatment trials in preclinical Alzheimer's disease, so people who don't have symptoms. And so we're participating in a study called A4, which I'll give you the full name in a second, but it's just easier to say A4, where we're trying to capture people before they reach the mild cognitive impairment stage and treat them with a drug to see if we can prevent or slow down the development of the disease. And so this is called the Anti-Amyloid Treatment in Asymptomatic Alzheimer's Disease Study. That's why we call it A4. It actually was a really nice New Yorker article about this, I think about a year or two ago. But basically this study involves, and we're actively recruiting for the study, we're trying to get 1,000 people actually in this study countrywide, where we basically say, you're normal, you're over 65, come here, and if you want to come into this study, and we actually get an amyloid scan in them, and if the amyloid scan's positive and they meet other criteria, they can enter into the study with treatment, with an immune-based treatment of the amyloid plaques in the brain, what's called passive immunization, where you try to clear the plaques with antibodies to the plaques. And so why are we doing this? You know, we haven't had success with drugs in symptomatic patients. Why do we feel comfortable moving along into pre-symptomatic? The reason is because we do think that probably there's the disease, the fire of the disease has already started too much by the time we try to treat people in these later stages of the disease, and even later, like mild cognitive impairment, and that maybe by starting these treatments before there's a lot of brain injury, that we might actually be able to sort of stop that cycle. And so that's basically what we're doing. There is a sort of ethics component. There's actually someone within our department who's quite, or in the memory center, who's quite interested in trying to understand how to tell people their amyloid results, because this is one of the few examples right now where at least we're telling normal people, look, you have amyloid in your brain, and how do they react to that, and how can we best, you know, reveal that information in a way that sort of supports them. And there are obviously positive or negative psychological issues that can arise from that, although fortunately we haven't had much in the way of issues with that up until now. Right now, clinically, we don't do these scans in normal people because we still don't know what they mean. There are people who, again, have a positive scan, and as long as we've been following them, haven't developed symptoms. And so it's not clear to us right now that it's a good thing to tell people that, because they might never have symptoms in the future. So I think this just sort of shows the breakdown of this study. But I think I'll end with that, and I guess answer any other questions that you guys might have for me.
When you intercept a early stage when you identify, at least to some satisfaction, that you're in an early stage progression of the disease, are there any other recommendations in terms of keeping the disease modified or slowed down? For example, is there a nutritional component? Is there a sleep component? Is there anti-anxiety component? Are there things that can be done in terms of lifestyle that are at least have some benefit to slowing the disease down?
Yeah, no, it's a great question, and actually you could argue that, and part of why amyloid imaging isn't covered by insurance is like, well, what difference does it make if you get the diagnosis right, even in the mild cognitive impairment stage? Like, okay, you're still the disease is gonna occur or not occur in individuals. I would argue that, we as a society care about prognosis, that matters to people in all sorts of diseases, and so I would say that, that it is important to know early on, just to know what to expect, but I think it's also important early on to give you more motivation to try to do the kinds of lifestyle things that are potentially helpful in slowing down the disease. Things we should all be doing anyway, but I think it gives you a little bit even more urgency to do these things. And so there's data that, probably the best data, and the thing that I push my patients most to do, as much as there's all this stuff you'll see about luminosity and all these great computer games, and people will try to really push those things, and yeah, there's some data that they help. The best thing is exercise. Over and over again in studies, exercise has been shown, aerobic exercise has been shown to be the best, the thing that most enhances cognition. And these are even placebo-controlled studies where like one group does stretching exercises and the other does aerobic exercise, and the aerobic group does better. In fact, actually, I mentioned your hippocampus gets smaller as you get older. There's even some data that if you intervene with exercise, that can reverse that effect to some extent. So I really push exercise as the thing that's most important. I do think mental and social stimulation, though, probably also are helpful in slowing down the course of the disease, and there's certainly data for that. Treating things like mood and anxiety are other things that can worsen symptoms, and so those are things that we often talk about. And diet, I think the biggest thing is a heart-friendly diet. I mean, there's some data with the Mediterranean diet specifically, which is high in fish and olive oil and things like that. That's an area that a type of diet that is healthy. But I actually think that any kind of heart-friendly diet is helpful because there's a sort of synergy in your brain, the brain injury between vascular disease and Alzheimer's disease, and that vascular disease seems to speed up Alzheimer's disease in people and diminish your kind of ability to compensate for the Alzheimer's disease. So the same amount of Alzheimer's disease in your brain when you don't have vascular disease might not produce symptoms, whereas in someone with vascular disease it would produce symptoms. And so I really try to push that as well. Yes?
What are the drawbacks of prescribing drugs like Namenda and Aricept at early stages?
So,
Side effects.
So the drawback for Namenda at early stages is it doesn't work. So that I consider a major drawback. So Namenda is one, partly because of advertising that a lot of clinicians start physicians on very early, but there's no data that helps until more moderate to severe Alzheimer's disease. And the drug company has tried to do those studies because it's a much bigger market if you can prove that it works in mild individuals, and it just hasn't shown any evidence. So that would be one I wouldn't give. Cholinesterase inhibitors, like drugs like Aricept that you might hear of, or Razidine, or Exelon that are on a lot of commercials, those it's a little murkier. Certainly in mild Alzheimer's disease, they have benefit. Is the benefit as good as we want it to be? No, but if you look at large populations of people, they seem to make you symptomatically like what you would have been 9 months ago. Or 6 or 9 months ago. And so they have some benefit. There's some evidence that they delay time to nursing home placement as well. And so I think actually particularly in more mild patients, that little boost that you get from it might be enough to allow you to function a little bit better than if you weren't taking the medicine. Whereas you can argue in later disease stages, it's less clear whether doing a little bit better matters to some extent. In mild cognitive impairment, it's very debatable. So these drugs actually help in normal people to some extent. So the drugs, you can give them, there's been studies in fighter pilots where their reaction times are faster. There are people in their 20s with Aricept. But it has side effects, so like stomach upset and loose stool, and so not a lot of 20-year-olds are signing up to take Aricept. In mild cognitive impairment, there's a little bit of data that it could delay the time to developing Alzheimer's disease, but there's other data that hasn't supported it. And so generally I make that a decision between me and patients in terms of how aggressive they want to be.
One other question, Doctor. There have been studies about chronic alcoholism having a negative effect on Alzheimer's. So does that necessarily mean that people should be more cautious in alcohol consumption when they're in this sort of early stage identification?
So I think I generally would say that I don't stop people from drinking when they have this disease, but it definitely, not so much for toxicity, but it definitely exacerbates people's symptoms. So what I do talk to people, I mean, I think one of the things that we all have to face when we have these conditions is still maintaining our quality of life and our enjoyment of life. And so if someone likes to have a glass of wine with dinner and are having some mild symptoms, I don't necessarily say don't have that glass of wine. What I might say is have half of a glass of wine as opposed to a full glass of wine. So when you have cognitive symptoms, the things that affect us normally, like poor sleep, is another thing you mentioned earlier, or alcohol or anxiety, they affect you that much more when you already have memory symptoms. So when I have a bad night's sleep, like last night my kid came in the room and started kicking me at like 4 in the morning, because I don't know why 4-year-olds can't sit still at night. If I have a bad night's sleep, I can kind of compensate for it. I can kind of marshal together my attention to kind of pull it together. People with Alzheimer's disease, even mild, very mild disease, they just tip. They can't compensate for those kinds of things. And so a little bit of alcohol might have a bigger effect on them. I'm not so much worried, I mean, obviously if they're alcoholic or they're drinking large amounts, then I would want to stop it. But if you're I don't stop people from drinking alcohol, but I do suggest that you're going to be a little more affected by it, and maybe you should kind of cut back a little bit. Right now, again, in normal people, we don't do it in anyone, though, unless you're in a clinical trial, because we still are not sure what it means. And again, we don't know if everyone with it will develop Alzheimer's, or or some people are resistant, and so we're not quite there yet. I think the minute we have any kind of more disease-modifying medicine, a medicine unlike Aricept that actually slows down the disease, suddenly we're going to be doing a lot of these kinds of scans.
Do more people that have a higher intelligence get Alzheimer's? Because I've had a lot of friends that have gone to the top colleges that have all died of Alzheimer's.
Yes.
They don't put that in their brochures for the colleges. So in reality, actually, it's the opposite. So people who are not necessarily top, I don't think anyone's done a study of Harvard versus Penn, the higher educated you are, the lower your risk is of developing the disease. And there are a number of theories out there, and one is that there's something protective about being mentally active, and I think that against the actual disease itself, which may be the case. The reality is, what I think is, it's just that the disease, it's basically life is to some extent a race against time for our whole body in terms of what things sort of fail us first, and just like physically, if you're in better shape, you can handle a knee injury better than if you're in less good shape. If your brain starts at a higher level, you can probably handle more Alzheimer's disease before you develop symptoms of the disease. And so people who are more educated tend to develop the disease later in life. And because of that, they tend to die of other things before they develop Alzheimer's disease. So the prevalence in more educated people tends to be less than less educated people. There's a little bit of data that once they get symptoms, they go a little faster because they've harbored more of the disease, and then they just kind of decompensate. And there actually are amyloid imaging studies showing that more educated people at the same level of disease actually have more amyloid in their brain and other signs of degeneration than people who are less well educated. So it's protective to some extent. The reality is that anyone can get Alzheimer's disease. I think there was someone all the way back there, and then I feel bad. Never good to be in the back of the room.
Is there any sort of relationship between a high red blood count in your blood and amyloid? Or any blood, related issues that you found that connect?
No, not really. I mean, there are blood-related risk factors, risk factors that can be detected in the blood for the disease. So there's definitely evidence that the so-called metabolic syndrome, which is associated with people who have type 2 diabetes, obesity, hypertriglyceridemia, things that you can pick up in blood, increase your risk of developing amyloid and Alzheimer's disease. But nothing more from a risk factor standpoint. You can see that people are trying to measure amyloid in blood, and there's and other markers, and you probably have seen, because there were a couple big sort of media things about blood tests for Alzheimer's disease that may help us, but they're still at, I think, pretty early stages. You had a question too. Oh, I'm sorry. Nope, you can go there. Go next.
I've noticed that there are perhaps an increasing frequency of ads for herbal remedies and over-the-counter drugs and even homeopathic treatments that are supposed to improve your memory and suggest that it will affect things like Alzheimer's. What would you say to the general public about ingesting random substances to improve your memory?
Go for it.
Yeah, I would say do it all, as many as you can find. So I mean, I think that's I detect your cynicism about that, and I share some degree of cynicism about it. I mean, I do think that, it's reasonable for people to try things if they're relatively safe and they're willing to spend the money on it. There is this sort of, now I'll get on a political, there is this notion that drug companies are evil and that natural medicine is like, the good guys. And the reality is that many of these companies selling these supplements are very much for-profit companies. And so they will push the limits of what they can advertise, knowing that the FDA actually doesn't have the money to actually enforce or to the degree that is necessary to essentially block them from making the claims that they are. And so I would always be very cautious about trusting anything that you see in that way. And to some extent, even their economic models are built on this idea of like, how much can we get away with saying before we run into trouble. That being said, I'm always happy as a physician to hear what people are hearing in the public about various remedies, and at least thinking about it with them to see if there are things that make any sense, and certainly if they're safe and not overly taxing from an expense standpoint. You want to give people the opportunity to try things. Although I'll always say, like, I'd rather you spend that money on a gym membership and being on a treadmill, for an hour and a half a day. If you're really looking for, I can't tell you how many people are like spending all this money doing all those kinds of things, yet I can't get them to exercise. And if you really want to focus on something, focus on exercise. You had a question.
Is there any evidence that polylingual people have less Alzheimer's disease?
Yeah, actually that's a great question. So I believe there is some evidence. I don't know the literature all that well for that particular area, but there's some argument, again, part of this cognitive flexibility that more educated people have, that you're better able to kind of compensate for the disease if you're bilingual or multilingual than you are if you speak a single language. And so there does appear to be some relationship. How strong that is, though, I'm not sure. We'll do one more question.
One more. All right. You mentioned about a genetic link. I just wondered, like, if you don't see any signs of it in siblings, does that kind of make you feel a little bit safe?
So it's definitely the case that if you have siblings with the disease, first-degree relatives, so those are siblings or parents, kids too, but that doesn't really apply here, that if they have the disease, the more members of your family that have the disease, the more your likelihood is of developing the disease. Particularly, again, if it's developed more in your 60s and 70s, a little bit on the earlier side. People who, in reality, again, the age effect just dwarfs these genetic effects. So you take an 85-year-old, whether or not they've had a family member with the disease, they're still at very high risk of it. But certainly having a number of family members live late into life without the disease is comforting. And there's a couple of genes that seem to be protective to some extent against the disease. And I think as we study larger populations and look at genes, we'll learn a little bit more about those, and those might be things that will have a clue towards therapeutics as well. The only other thing I'll say, actually, and I think Jessica, one of our coordinators, I thought I saw her here, is back there, that we do have materials about the Penn Memory Center if you guys have any interest in learning more about our center. There's also a really good website as well. So, thanks.
Well, this is a very serious topic, and thank you all for coming, and thank you, Dr. Wolk. That was
No problem.
absolutely fascinating. You had some very serious students taking notes. Is there a
Good.
quiz?
There is.
But this is the Center for Healthy Living. So you can do your aerobic workout down the hall in the fitness center. You can join us for line dancing on Wednesday mornings at 7:45. You can take a language class here, and you can play bridge. So we want to exercise your brain and your body, okay? And we'll see you back here. You can sign up starting Monday for the third session, the one in April, which is on the 17th.